Thanks for the invitation to this course. I will be speaking on parasites in the oral. The presentations can be extremely varied. This 20-year-old male presented with diplopia, worse in upward gaze. This boy primarily presented with a forward bulge of right eye for a period of 1 month. This 16-year-old boy presented with diplopia and proptosis, the diplopia getting worse in the right gaze. This girl presented with a swelling at the medial canthal region under the conjunctiva. This boy had recurrent episodes of swelling causing eyelid droop on each of the occasions. This female had been having recurrent episodes of redness and inflammation, was being treated as a patient of non-specific orbital inflammation and had received steroids and had had partial response on each of those occasions. This girl presented like an orbital cellulitis. She presented with acute swelling, drooping, double vision, suggestive of an acute orbital inflammation. This male presented with an abscess appearing under the temporal conjunctiva and pointing as an external pus point. What was common amongst all these patients? The imaging in all of these patients showed a cysticercosis, a parasite. This is the first male with diplopia and ocular mobility restriction, and what you find is a parasite in the inferior leg fascia. This is the cyst, and you have a scolex there. This 8-year-old boy with proptosis also had an enlarged muscle with a cysticercus. This boy with proptosis and double vision again had a muscle swelling and an parasitic cyst. The subconjunctival cyst or a mass was also a thickened muscle with a cystic area with a scolex. The one with the recurrentosis presenting with the recurrent episodes of inflammation in the superior orbit again had a parasite in the superior rectus muscle and the scolex is visible. This girl also turned out to be the one with recurrent attacks of inflammation treated as non-specific orbital inflammation, also had a cysticercosis. And the same was true for the girl with presentation as an acute inflammation where there was an enlarged superior rectus muscle with a cyst and a scolex. Subconjunctival abscess, when it was drained out, showed a cysticercus cyst with scolex coming out. So all of these are orbital myocysticercosis. So we need to be familiar with all these presentations and pick up these cases uniquely as well as follow it up with the radiological or imaging to establish the diagnosis. We know that cysticercosis occurs is caused by the larval form of Taenia sodium. It is prevalent in several parts of the world. It is one of the common causes of proptosis in India. We know that humans are accidental intermediate hosts, the definitive host being human adults, and the intermediate hosts are the pigs. But the cysticercus form is when you are ingesting the eggs from the feces and these develop into cysticerci in the muscle and the brain. So ingestion of contaminated food, I am specifically with salads which are not cooked and not cleaned well enough, are the commonest source of infection or infestation in India. There can be systemic involvement involving eye is not such an uncommon presentation. You can have the intraocular manifestations, which you are all familiar with, and the extraocular ones, which involve the muscles and the submental area. In the series of 181 cases that we have seen, there is a slight male predilection and age group varying from children to late adulthood. The ocular motility restriction is the commonest presentation. Proptosis is a common manifestation. Recurrent episodes of redness, swelling and pain are a fairly frequent presentation, and they must be a cause for thinking about cysticercosis. But presentation as a recurrent ptosis is something that really needs to be watched out. The various muscles are involved in the myocystic but lateral rectus is the one that is most commonly involved. The diagnosis is clinical and imaging. Serology does not contribute much to the diagnosis and is often negative. The CT scan, it is important to ask for 1 or 2 millimeter cuts so as to not miss out the cyst. So when you see the hypodense cyst with an hyperdense pollex, that is a very clear indication of myocystic, and the surrounding myositis is very characteristic. This is a superior rectus involvement that you can see here. MRI gives very good soft tissue delineation as well and demonstrates the cyst with surrounding inflammation very well, and you can see the appreciatus pollex quite easily. You can see the image in a T1 weighted image like this, or in a T2 weighted image with a whitish appearance like this. Ultrasonography is useful, particularly for follow-up of these patients. You can do it yourself and you can see how the cyst is reducing and gradually merging with the surrounding muscle structure. You can find out that the disappearance of the cyst takes much longer than the clinical disappearance of acute inflammatory sign, and it may take up to 6 to 9 months for the total disappearance of the cyst. Some inflammation, though, may still remain, some fibrotic changes remain in the area possibly for much longer. Histopathology is possible only in those rare cases where there is a spontaneous extrusion or where a surgical excision is needed. Medical management today is the mainstay of treatment. Surgical removal was the norm till 1993, when I came across a case which was, so this is a patient who's had a lateral orbitotomy. This is some of my old slides. The first time I treated a patient with myocystic was one with a cysticercus very close to the apex, and the patient was Mr. Sani, still following up with me, and I thought it was too risky to go and venture near the apex, and thought of the albendazole treatment, taking a cue from the neurosurgical treatment, and those were the first treated cases of myocystic. There were no reports, and I presented my series of 21 cases in 1995 and got the Ramachandra Award for that. Today I prefer a regime of 30 mg per kilogram for 2 weeks rather than the 15 mg per kilogram for 4 weeks, because I find the cure rates are much higher with this, and the side effects in terms of liver function are not significant. They are usually combined with low dose oral steroid. We do not use a much higher dose of steroids. So the response is exceptionally good in almost 97 to 98% cases, where you can see the disappearance of the proptosis here in the patient on the left and the treatment results on the right. The inflammatory signs disappear. These cysts which you see subcondylobally, they tend to disappear after management. And the ocular motility restrictions which are present start responding, and within a few weeks to months, you are able to get rid of the ocular motility restrictions, as you see here, left pre-treatment, right is the post-treatment. So ocular motility restrictions show a response a little slower than acute inflammatory signs. And you can see the reduction in the size of inflammation over a period of 4 months, where you're left with a thickened muscle, but the cyst has disappeared and the scolex has disappeared. Toxicity of albendazole is usually mild, and increase in liver enzyme levels is the only thing that you look for, and you find mild increase in SGOT-HTP, but that normally does not have any clinical significance. Acute inflammatory response within days of start of the medical treatment is often seen, but probably in just about 2 to 3% cases with an acute inflammatory presence, inflammation like this, which responds well to the use of steroids. Rarely responding is exclusion of cysts also takes place. So it is important to have a high index of suspicion for myocystic cirrhosis in patients who are in the endemic zone. Diagnose it on the basis of the clinical features, carry out imaging, and the response to medical therapy is excellent. Hydatid cyst is a much rarer condition in India. It is caused by the larval stage of Echinococcus tapeworm, and you can get a classical picture of a large cyst in the orbit. It shows the characteristic double wall sign, a spoke wheel pattern, and the water lily sign. The serological tests are more reliable in hydatid cyst, and the tests do sometimes reveal a positive histology. Management is largely surgical by orbitotomy, and you can aspirate the cyst intraoperatively to debulk it to prevent its rupture during surgery, because a debulked cyst is much easier to dissect, and you need to remove only the endocyst. You can combine the medical management with the surgical management in order to combat the effects of spillage and the secondary effects thereof. And the results of the combined therapy can be quite gratifying. Once again, reiterating the invitation to the Asia Pacific meeting in Delhi, September 26 to 28. Thank you.
I had to go through the lady presented, a 30-year-old lady presented with very severe acute gastrectasis with a blood displacement. So I just got the CT scan and once she responded to the antibiotic therapy, and we got this scolex in the retinal gland. So she responded to albendazole and steroids, and I went through the literature. There were only 2 cases reported. So I reported this case, and it was perfectly managed medically. She took about 6 to 8 weeks to resolve.
Yeah, it has been reported, so I do not have lacrimal gland cystic fibrosis has been reported, as you said, and it also responds as well to medical management. I did not have any in my series.
I had to go through the literature. I don't know whether it is important to report or not. When I realized that no, this should be reported, so I reported somewhere in 2006, I think.
Superior weak involvement is also seen at times. I now have 3 cases.
We'll be going ahead with the next talk.
So we're giving this talk on non-specific organ syndrome and having a chat with Roshni. Ideally, I should be following her because we talk about the logic of progression as well. But in a way, it's right that this comes first before that, because I think as ophthalmologists, we're all guilty of the crime of managing orbital inflammation or the pseudotumor, responding them with steroids, not really having done that particular workup. So it's not so maybe practically this kind of makes sense as well. And we all know very well the old terminology, and underscore old because we should not be using the term anymore, is the pseudotumor or the orbital. There are a few other synonyms that you might see in the literature of spoken language, non-specific organ inflammatory syndromes or disorders, NSORS or MSOID. And a few years ago, it used to be called idiopathic. And as we know very well, as we start investigating, applying our knowledge of systemic immunological diseases to orbital inflammatory diseases, i.e. even thyroid for that matter, we are now able to narrow a lot of these conditions that we will consider tumors or IOIs. And so the idiopathic is becoming a smaller and smaller and smaller piece of the pie than what it was thought before. Okay? Here's an example of a patient who was presenting with us with a known history of hyperthyroidism, acute onset of redness. We just finished a session on thyroid orbitopathy. As always, they typically appear on a Friday afternoon. And obvious diagnosis, active inflammatory orbitopathy. Okay? But there were a few atypical things which prompted us to doing an investigation and imaging for him. And you can make out it's not the muscles which is a major offender over here. The muscles are not necessarily large, but you can see a diffuse infiltrated lesion along the superior orbit and superlateral orbit. And incidentally, the eye on the left side, there's an interphone lesion as well. In other words, a lot of these patients present with other manifestations and sometimes other diagnoses as well, but may end up actually having inflammatory orbitopathy as well. So, I'm going to give you a little overview, including the principles and concepts of management of these patients as well, and what is the driving principle behind inflammatory orbitopathies. There's only one inflammatory orbitopathy where you don't need a biopsy, and that's thyroid orbitopathy. So we will be covering that. Barring which, practically every other case should have a specific diagnosis, or at least when possible biopsy, before we start managing them as non-specific orbital inflammation. So the definition is all orbital inflammations are specific and controlled otherwise, but unfortunately they all have similar common signs and symptoms and presentations as well. And that's why we think we've seen hundreds of these before. The manifestations can be similar, but actually the diagnosis will be completely different. Okay? There are specific nuances which are different to every ethnicity, the gender, the age, and geography where it is. And the response to steroids is what actually helps us diagnose these patients, but unfortunately manage or even mismanage these patients, because all of them respond to steroids. So you think medically this is idiopathic organ inflammation or non-specific organ inflammation. No, you're treating the patient right, but with the wrong diagnosis in mind. And that again underscores the value of biopsies for these patients. And why is it important to categorize these patients appropriately? Because the prognosis changes depending on the nature of the diagnosis, and not all non-specific organ inflammations are the same. So principles of management, these are number one, the use of corticosteroids. You heard that in the thyroid orbitopathy talk. There was some evidence that non-steroids may help in a subgroup of patients, but for surprisingly, for an inflammatory disorder, non-steroids really do not do much for these patients as well. There used to be some information about radiation, again it's a treatment of last resort, not the first resort, so you should not be embarking on that. But of course, there's an increasing role of immunosuppression therapy. Now, with the current age of biologics that our oncology colleagues use, is becoming more and more prevalent in this as well. So this is how I see orbital inflammation. First of all, to make sure you rule out pseudo-orbital inflammation. Dr. Santosh now showed slides of orbital inflammation with patients with retinoblastoma and extraocular extension, presenting as an orbital cellulitis in the picture. It's not an orbital inflammatory disorder. Okay, so pseudo-inflammations. Once you rule it out as a true inflammation, you have to make sure that you're not treating an infectious condition, because that algorithm comes completely differently. And once you determine it's a non-infectious physiology, there are certain chemicals which also can cause inflammatory disorders as well, pamidronate and all those things which give osteoporosis, can cause orbital inflammation. And then comes a huge group that Suresh is going to talk about, which is specific organ inflammations. And number one up there is Graves' orbitopathy, specifically highlighted IgG4 disease, and there's another condition which is sarcoidosis, which is now becoming increasingly recognized, especially in our population. And only when you wrote all of these things out, that's a small group, and I think I'm upset with Saru, but we need such a small topic. No, that's just kidding. Okay? And it is quite significant and quite common in terms of frequency as well. It can be varied in presentation, can be unilateral, bilateral, can be a single episode, this is a recurrent episode, and very initially, although we thought that it was a painful inflammation, there are patients with sclerosing orbital tumors that do not present with any pain at all. And once again, highlighting the role of diagnosis exclusion, biopsy is always highlighted. And I think we are overdiagnosed. There's one condition we're diagnosing a lot of this, and that's non-specific organ inflammatory syndrome. So here's why we talk about stool inflammation. This patient was on and off steroids for inflammatory orbicular tumor. He's got an infiltrated lesion, very superior over, easily accessible. Go ahead to a biopsy, consider this as lymphoproliferative disorder. I don't call them lymphomas because lymphomas is a pathological diagnosis. The treatment for this is completely different. Okay? So how do you go about diagnosis in a case of non-specific organ syndrome? Of course, you do a complete and an extensive ophthalmic examination. It's very important to review the systems because a good proportion of these diseases, especially in certain age groups, have systemic involvement in addition to organ inflammation itself. All patients should ideally have as complete an inflammatory workup as possible. We don't do a shotgun approach, but based on the clinical differential diagnosis, we order the proper investigations and or now, in the past we used a term called venous granulomatosis. We don't use terms like that anymore. It's granulomatous polyangiitis, angiitis, granulomatosis polyangiitis, which is a specific term that we use, which now can be seen as presenting as idiopathic organ inflammation because all the lab tests are negative. And you can still see limited forms of these so-called venous granulomatosis. But if you do not do all of these investigations starting in those patients, then you're not really treating the patient with non-specific organ inflammation syndrome. We'll talk a little bit about imaging and finally some special situations as well. Okay? So the spectrum of patients can present with is most commonly anterior. Anterior, and you and I have all seen this case of so-called scleritis, so-called scleritis, so-called sclerodermatitis. I think they still come under the category of non-specific organ inflammation. So yes, we all know that we start them with NSAIDs and steroids, they get better. Thankfully, it's a one-time episode, something that could come with different inflammation. That's one entity where the biopsy may be a little challenging. Barring which you can get specific cases like dacryodermatitis, as I shared before. You can get isolated oculomyositis. It's a specific entity that we use, not just the spiral myopathic inflammation or oculomyositis as well. And the challenging ones are the posterior ocular inflammation are right at the apex, where then the diagnosis may be not easy, maybe easy, but biopsy can be very difficult. And in the years past, one disease which was very, very difficult to manage is the sclerosing orbicular tumor, we used to call it. And this is one disease I think we are starting to make strides because of the advent of AIOC steroids aggressively at the earliest phase of the pre-fibrotic stage of the disease. We are now even able to see reversal of some of the fibrotic signs that we used to see in the past. So that's something I really want to take on board as well. And there can be varied presentations. Not all organ inflammatory diseases are acute or hyperacute. You can get intermittent subacute and finally chronic sclerosing. And remember, some of these may have systemic presentations as well. What investigations do I use? Generally speaking, for most organ diseases, I go not to ultrasound but to CT or MR because I'm poor at ultrasound. But more importantly, you're able to make bilateral comparison. Same thing as thyroid and a lot of other organ tumors. Which investigation do I use? If I'm going to use it as a one-time deal to clinch a diagnosis, to make a diagnosis, decide on management, I go for a CT scan. There's emerging evidence of the radiation effects of CT scan and the late developments of cancer. So somebody's going to require the current follow-up investigation. Then by default, you go to MR. And MR can pick up certain features that the CTs cannot pick up, but as a one-time episode, I generally go to a CT scan itself. Okay? So, make a proper diagnosis, do an appropriate workup, do an appropriate imaging, and then you go ahead and decide whether you're going to do an empirical management or you're going to do the tissue diagnosis. So, the minimum workup you should do before you start managing non-specific organ inflammatory syndrome is disease-specific and disease-related and management-related. By that I mean you want to make sure the systemic diseases like diabetes doesn't exist, there's no tuberculosis, because whatever immunomodulatory agents you're going to give is going to kill the patient. So the treatment should not be killing the patient. So that's very, very important. And in special situations, you do an extended workup. Keep a very, very low threshold for biopsy depending on the clinical type of presentation as well. I don't think there's much role for needle aspiration biopsy, but by default, most of them should be an incision biopsy. And this is relatively easy for anterior lesions, lateral lesions, and in difficult to access areas, you can even do a transmural endoscopy, critical orbital lesions for intracranial biopsies in patients with things as well. But keep in mind, there is a possibility of sampling error. Either lead-in biopsies are representative site because biopsy is a very big part of the lesion than the central part of the lesion as well. So in our practice, it should be all cases until contraindicated, and the indications will be focal. anterior, accessible, and safe inflammation as well. And these are situations where biopsy will be difficult, either because the patient is unfit for local or general anesthesia. As a rule, hard to sell and open biopsies for patients, children, especially the parents are unwilling. Diffuse sclerotionitis, we don't know where to go ahead and do a biopsy. Optic pyelonephritis for the risk of vision loss. And the apical so-called Tolosa-Hunter syndrome is where we end up not doing a biopsy, barring which you should be able to do a biopsy. So once you have more or less categorized these patients as truly non-specific, once again the same spectrum of management of corticosteroids, we talk a little bit of oral and IV methylprednisolone. NSAIDs are out unless in special situations, immunosuppressive therapy, biologics, and last is radiation. So this is my approach to inflammation. It's like terrorism. If you use a soft-hearted approach, you're not going to kill it. So, okay, for terrorism should be tackled rock hard, like how Singapore does. Okay, so you want to hit hard on these patients once you have a proper diagnosis, and that's where we use steroids. And we want to use steroids not in a half-hearted way, but good doses. Generally, in adults, it's anywhere from 1 to 1.5 milligram per kg body weight. Remember, in children, they don't respond to the standard doses. They may want to really quell the inflammation with a much higher dose, 2 to 3 to even 4 milligram per kg body weight. And that's how you quell the inflammation when we start tapering the treatment off as well. In potential vision or life-threatening inflammatory diseases, you can talk about IV methylprednisolone, different dosage regimens as possible. The most important thing is duration. How long do you continue? When do you stop? Basically, you want to completely control all of the inflammatory signs until there's reversal to near normalcy before you want to start tapering the dose of steroids over the next few weeks to months, and that's arbitrary. And we'll talk about what happens when the inflammation comes back in a short while. And there are different forms of steroids which is available. So when you complete a course of steroids and there's a first sign of error, what do? Always make sure your diagnosis is right. And if you're sure about the diagnosis, that's when you consider the various disease-modifying anti-inflammatory drugs which are available, and all of which we are kind of familiar with as people who are managing uveitis and other inflammatory disorders, including thyroid atopic. But not all immunosuppressants are the same in terms of non-specific organ inflammation syndrome. There are certain conditions like myositis where cyclosporin specifically is more effective than the other conditions as well. Cyclophosphamide, which is quite a legal drug in itself, is very specifically indicated and very useful for vasculitis and potentially life-threatening organ inflammatory disorders. Myositis, again, methotrexate can be useful, but keeping in mind, when a patient does not respond to the typical drug of treatment, could be either because they got your diagnosis wrong. Sometimes these patients have a genetic mutation which makes them unresponsive to these kind of immunological manifestations. You can now do genetic tests for these patients and they have those antibodies. Then you can actually switch them to a different class of immunosuppressive agents as well. And mycophenolate is readily available. It's quite expensive in our country, but it's something that immunologists are using it more and more in the management of these disorders as well. What is the role for biologics? Biologics are legal, but also very effective, again, for a specific subgroup of patients, depending on what the pathogenesis is. So basically, you are again familiar with these groups of drugs, which is anti-TNF-alpha agents, which is basically useful. They are given in the form of injections. The patients come once a week or once a month intermittent, and make sure to get all the inflammation, and then they kept on maintenance dose as well. You also know about rituximab, which is used for other immunological, including lymphoma-like disorders. That's specifically targeted against B-cell-mediated inflammatory disorders as well. They're quite expensive and again potentially legal as well. So again, it's not only a cost issue, but a risk qualification issue as well. So this is the last slide I'm going to show you. Are all non-specific idiopathic or organ inflammatory disorders the same? In children and adults, they're quite different. Number one, adult organ inflammatory disorders are truly organ inflammatory disorders, whereas a good proportion of pediatric organ inflammatory disorders have intraocular inflammation. These seem to be associated with a higher amount of eosinophilias. Full blood count does have value. We already talked about a higher dose of steroids in children compared to adults. There is a greater risk of bilaterality and systemic disease involvement in pediatric organ inflammatory disease compared to adult organ inflammatory disease. So you want to keep that in mind. You can have a higher recurrence rate with more likelihood of a pediatric organ inflammatory patient is going to require immunosuppressants rather than just one-time steroids as well. Only problem is a higher threshold for biopsy and the side effects are slightly different. So in summary, non-specific organ inflammatory disorders are not that rare. Actually, we should be making proper diagnosis. Always rule out one of the specific organ inflammatory disorders, either in systemic evaluation or serological testing as well. Keep a low threshold for diagnosis. When in doubt, don't think about doing a repeat biopsy because it's something we already talked about. Manage them early, manage them aggressively, and when necessary, co-manage with this environment. So thank you very much.
Thank you, Doctor. You need to be sure about what you're looking at, and hopefully this IC is going to help you sort of, form an approach because they all tend to overlap over each other. Thank you.
Good afternoon, everybody. And I'd like to thank Sabri for letting me be part of this very exciting instruction course. My task today has been made very easy by Dr. Gavankar, who's given a wonderful overview of how to approach orbital inflammation as well as its management. I'm going to focus on a group of disorders which are the specific orbital inflammations. They sound confusing, they're sort of rare. However, they have a very distinct implication for the patient's well-being. So it's probably worthwhile taking the effort and time to understand the disease and also help the patient understand the disease. How I remember this set of disorders is, first of all, I try to focus on what is common amongst all these entities. And then focus on what is different in each of these. So what is so specific about specific orbital inflammatory disease? Each of these have very distinct histopathology. So we keep stressing again and again that biopsy is the way to go. And we have a specific pattern of organ involvement. So therefore the patient presents in a specific way. And obviously, as you've seen from the previous speaker, the treatment has to be tailored. We are looking at disease affecting the vessels, the vasculitis, granulomatous inflammation, sclerosing inflammation and IgG4 related disease, xanthogranulomatosis inflammation, and the set of disease for the transitional diseases. Among vasculitis, the major ones we focus on are Wegener's and Schwartz's. Okay? The second entity is very similar to Wegener's, however, it's associated with asthma. And as opposed to Wegener's, which needs systemic immunosuppressants, Schwartz's needs only systemic steroids. Polyarthritis nodosa is pointed here. It's okay. And hypersensitivity angioitis are classical examples of vasculitis. Orbital vasculitis is often in response to a systemic illness, pre-existing viral disease or medications. It can be associated with other connective tissue disorders such as lupus or even with Cogan syndrome, very rarely. Typically on biopsy, you are going to see vessel destruction and there's endothelial damage, fibrin deposition around the vessels, and this may be immune complex mediated or hypersensitivity mediated. Now, here it's worthwhile knowing that the way I go about approaching these patients of orbital inflammation is that biopsy is the first step, and then my pathologist actually tells me that, look, this is what it's looking like. Why don't you ask for the blood test so and so? So if she sees a pathology like this, I would most likely ask for ANCA instead of putting the patient through the entire drill. Wegener's may be systemic or localized, and in the orbit, it is very often localized. If it is localized, the prognosis is better. There may be proptosis, there may be a destructive orbital mass. A midline lesion is more likely to be destructive, whereas a lacrimal one is more likely to be isolated. There may be a sinonasal disease, there may be hearing loss, and other respiratory and renal involvement. Lacrimal gland involvement can cause dry eye. Other than that, the patient may have scleritis. This is one particular entity where orbital inflammation is associated with scleritis. There may be enophthalmos, bone erosion, and visual loss due to orbital vascular infarction. This is very often seen. In the last 3 years, of the 4 Wegener's patients I've seen, 3 of them have had some amount of visual loss. ANCA may be negative in the beginning. As the disease progresses, may become positive, and as you treat it, it may become negative again. And when you follow the patient over some time, the other manifestations such as pruritus may develop later. The hearing loss may develop later. Cyclophosphamide is very, very effective, and you're talking about a time range of treatment of about 1.5 to 2 years. So, for me, redness or vasculitis means these are diseases which are more painful than the other ones. There's more tissue destruction. There's a higher incidence of loss of vision. Next, we come to the granulomatous inflammations, which could be including foreign broadleaf granulomas, including dermoid cyst-related inflammation, which is very common, and sarcoidosis as well as ulcerative sarcoidal inflammations. These will be having non-caseating granulomas. Very important to know, because given our frequency of cause disease, we have to differentiate it from the caseating granulomas. These present more with a mass effect, so biopsy is commonly needed. They may be uveitis, chorioretinitis, conjunctival nodules, optic nerve sheath sarcoid, and skin nodules. If you look at systemic sarcoid, 50% have ocular involvement and frequently bilaterally lacrimal glands are involved. Whereas the patients that come to the ophthalmologist with the orbital involvement, about 70% will have mediastinal lymphadenopathy. There may be a sequential development of disease, such as this patient who developed dacryoadenitis, later on went on to develop the skin lesions. And as the lacrimal gland lesion resolved, the higher lymphadenopathy increased and finally led to collapse and fibrosis of the inferior lobe. This patient, for instance, presented with a typical mass lesion. Now, this is one patient, very, very distinct mass lesion, and this is one patient where clinically you might suggest to the pathologist that, okay, look, stain for the fungal elements also, because this will come into the differential diagnosis. She also had lymphadenopathy. Rarely, a sarcoidal orbital involvement may develop, optic neuropathy. Within a week of detection of the sarcoidal disease, she developed an RMD and we had to start steroids very promptly. It's commoner than previously believed and it evolves over time. We need to differentiate it from cause. Often pulmonologists, they keep arguing amongst themselves. Do we give ATD? Do we give steroids? Do we give steroids under the cover of ATD? There's not much published literature on it. What I've understood from the microbiologists around is the tests that are recommended, like quantiferon, etc., are not very effective for orbital Cox disease. The one thing that may be useful is a PCR. Sclerosing inflammation typically presents with extensive fibrosis in the orbit. The cellular infiltrate is less. The commonest source is the lacrimal gland, and it may be associated with systemic fibrosclerosis. Typically, the tissue planes are obliterated, it's infiltrated. It can extend outside the orbit, go into the paranasal sinuses, go into the temporal fossa. And when you take the biopsy, you feel that it's a very hard mass, it's almost gritty, it's difficult to cut. This has a poor response to corticosteroid radiation in 30% of the patients, but the earlier you start the treatment, the more likely that it's going to respond. IgG4 related disease, I've tracked it together with this because now it's found that more and more orbital inflammatory disease is also associated with immunoglobulin G4, and particularly in plasmacytic inflammation and fibrosis. It may involve the lacrimal gland in 80 to 90% of the patients and may progress to lymphoma. In fact, it's so common, previously unsuspected. There was a group who went back and seen their old slides of, so to say, quote-unquote, non-specific orbital inflammation. and they had to revise their diagnosis in 40% of the cases, that they found that it was actually all IgG4 related disease. And particularly when there's bilateral orbital involvement or multiple foci of orbital involvement, it makes sense to take multiple biopsies, because it's a progressive thing. It's been reported that in the same patient, part of the disease may be IgG4 related inflammation, part of it may be a lymphoma. And the one differentiating feature that has been reported is that the part that is turned into a lymphoma enhances more on the MRI. So these are basically infiltrative disease and difficult to manage. And it's a new concept that there's an association of IgG4 disease with sclerosing inflammation and as well as lymphoproliferative disorders. Xanthogranulomatous diseases are characterized by chronic inflammation with lipid-laden histiocytes and giant cells. These have a typical yellowish appearance. It may look somewhat similar to xanthelasma, but then you think, no, it doesn't look exactly like the xanthelasma, and there may be orbital fullness along with the patient, along with that. Now, these are the entities associated with that. And what I remember for each of this, because these are a set of very rare diseases, that juvenile xanthogranuloma affects mostly the uveal tract and sometimes the eye, rarely the anterior orbit. Adult onset xanthogranuloma may be associated with adult onset asthma. Necrobiotic xanthogranuloma is associated with paraproteinemia, that is monoclonal gammopathies, multiple myeloma, and leukemias. And urgent cluster disease is associated with multi-organ involvement. Transitional disorders mostly have mass and infiltrative effects and can be actually included under lymphoproliferative disease as well. One of them is the Sjogren syndrome. By definition, any two of three involvement, lacrimal gland, that is dry eye, salivary gland, that is dry mouth, and autoimmune disorder would define a Sjogren syndrome. There is extensive destruction of the lacrimal gland acini along with inflammatory cell infiltrates. Tear levels may be low or normal. Always low in atrophic lacrimal glands, it may be normal in enlarged lacrimal glands. And there's long-term risk of development of lymphomas. Rosa-Dorman is another disease which presents as orbital mass lesion, and there's massive histiocytosis with lymphadenopathy. And typically for the histopathology, it shows a characteristic called emperipolysis, with the histiocytes sort of eating up the polymorphonuclear leukocytes, the phagocytosis of that. And the treatment is steroids and immunosuppressants. So the diagnosis of the specific inflammatory disorders include local signs and symptoms, systemic signs and symptoms, histopathology, and serum markers. And it's nice to have a look at what the specific serum markers indicate. When you suspect Sjogren's, look at SSA and SSB, but SSB is far more specific. dsDNA is going to be positive in almost all of these disorders, but if you see systemic features of lupus, it's going to have a much higher positive predictive value. ANCHOR is positive in Beginners, and you can actually monitor disease activity using that. ACE is positive in sarcoidosis. So the management of these disorders is a combination of steroids and immunosuppressants and continued monitoring for progress and adverse effects. We do need to do long-term monitoring since systemic manifestations may be late, and it's best managed as a team effort. I do acknowledge the efforts put in by my pathologist and my rheumatologist colleague in treatment of these patients. Thank you.
I'm going to be speaking on thyroid eye disease. It's almost, I think, everything of Dr. Gangadhar Chandra's IC encapsulated into one talk. talk of our session, following which we'll take some questions. So what I'll really be talking about for thyroid is just the clinical aspects of our day-to-day practice and things we need to do, just focusing on some of the things which I feel as a clinician I incorporate to sort of try and achieve a diagnosis of thyroid eye disease when it overlaps with some of the other diseases. So 3 questions. Does the patient have thyroid eye disease? If it does, then do I really need to treat it and how do I manage it? So, does the patient have thyroid eye disease? The commonest presentation you get is unilateral lid retraction associated with thyroid eye disease in almost over 90% of patients. It can be bilateral or it can just be unilateral, associated with some soft tissue involvement, which can involve the upper lid, the lower lid, proptosis, lower lid retraction, and finally extraocular muscle restriction. Most of these, it can either be one or a combination of both, and that should always raise a suspicion. The most important thing is the feature of lateral flare, in which the lateral 1/3 of the eyelid is raised due to fibrosis of the fascia involving the LPS and the lacrimal gland, giving this characteristic appearance. Often the disease is asymmetrical. So it is written in the books that it's very rare to have a unilateral disease, but I think in our population we do see a unilateral disease. Then, if the patient has it with the presentation, I also do take a little bit of history in detail. So here is a 28-year-old pilot who came, was not given a fitness to fly in spite of flying for a couple of years because he was told that he had thyroid eye disease. So he said, I've done it 3 times over the last year. I have new thyroid. So we went back and we said, let's do something simple as get a photographic documentation. So this is him about 3-4 years back. And that's him when he was a child. And though I also was trying to think that he could possibly have thyroid, I realized that with no family history, that was just the way he appeared. And he also went ahead and got his mother's photographs which had similar appearance. So it's not always a patient with a presentation like this will have a thyroid disease. On the other hand, this lady came saying that she had recently got a proptosis with swelling. But when we took a photograph about a year and a half back, you can see she already has the eye disease which has started with the lateral flare and upper lid fullness. Then again, coming to biochemical investigations, the basic tests that everyone usually advises, and it also depends a lot on endocrinologists, if they either just do a TSH as a screening measure, or you can do a T3, T4. What I personally prefer to do is a T3 with a free T4 and a TSH. And I now know the 5 or 6 endocrinologists I work with like what tests they want. So I usually go ahead and do something called a trap. But other than that, I just simply stick to these 3, which gives us the answer that we want. Now, trap in different labs have different meanings. So a lot of times the patients end up calling back saying that this is, what exactly do we need? Do you want a TSI? Do you want a TN? So it's actually just a combination of both these, which is what they test. So some labs call it trap, some have TSI as the name, though they are basically testing an entire range of hormones. This is just a general term. I do it because a lot of times the endocrinologists feel their treatment is based on this, though I don't think it really determines mine, but if they prefer it, I do it. So 70 to 80% of biochemical investigations turn out to be hyperthyroid, but there is an entity of 10 to 20%, and as we heard in the previous IC that there are a large number of patients who are euthyroid and will remain to be euthyroid, and sometimes they need to be treated irrespective of what the biochemical investigations are. Coming to imaging, I agree with Dr. Ganga that we don't necessarily do imaging in every case. If there's significant proptosis, there's a sudden onset of diplopia, restriction of movement, obviously acute thyroid ophthalmopathy, or in planning a surgical measure, then we go ahead with imaging. USG I don't do so much. In a lot of the endocrinologists have used to do it, send it and do it and send it to me, and I've encouraged them to not do it anymore. Yeah, if it looks something like this, which looks like an acute thyroid eye disease, and you want to rule out a dilated superior ophthalmic vein and access a screening measure. I am very pro CT scans, but not for every patient. Depending on the indication, you can pick up just early muscle fullness, straightening of optic nerve, or enlargement of muscles which causes the crowding at the optic or vital apex, for which you need to fuse and involvement of the lacrimal glands. MRI, I often find that other ophthalmologists who refer love doing MRI, and I always have the patient coming to me with an MRI because of, no, should we be doing a CT scan? But CT scan is still my modality of choice. So, if now we think that, okay, the patient does have thyroid eye disease, do we really need to treat it? So, you need to identify the phase of the disease. And this was a concept that we spoke about when in the early 80s, the natural history of thyroid was sort of charted out, and Rundle said that there are two phases, an acute phase and an inactive phase. And he basically made this graph which said the acute phase lasted for anywhere from a year to 2 years, and the inactive phase followed that. In this phase, this is when the inflammation acts the most, in the active phase, and which can respond to treatment. Whereas in the inactive phase, you're dealing with a stage where the inflammation is no longer there, and usually intervention treatment does not really have much effect. So what is disease severity then? Severity is the amount of deficit that is left in terms of squint, deviation, eyelid retraction. These are the functional deficits that's in the form of severity. This is the active and the inactive phase. Now when you want to classify this, Dr. Sampath spoke about the different classifications. So for some of you not here, I prefer to do something which was came up in the 90s by Moritz and Kurunin called the clinical activity score, which basically has 5 points, 10 points, and 4 to 5 features which are divided. So the first 3 features, actually pain, redness, and swelling, give you a better idea of activity or the active phase, where the functional, the last 2 points actually give you a functional deficit. This study was done based on the response to immunosuppression. However, what they have found is in a recent paper by Petros, they found that when they applied this clinical activity score and biochemical investigation and radiological investigation and put everything together, they thought this came the closest to really giving the severity and activity in terms of management of treatment, and is actually very straightforward to follow. So I always make it a point to mention and encourage the residents to write a clinical activity score after the examination of what they feel after they have gone, and we've actually put it up in the OPD so that they can just quickly do a run through it. The different classifications are there. I don't really use this. The ITIS classification, which was proposed by Whitman and Dolman, I like the fact, as previously said, it is a very time-consuming, but what I like about this is the vision, inflammation, stress, and appearance points. We have sort of summarized these points and made our own OPD sheet for examination, which doesn't really split hairs, but gives a better idea so that you don't miss out on any vision-threatening loss of thyroid eye disease. So how do I manage it? These are the basic management modalities. We're just going to deal with this case-wise. So this is a 22-year-old girl who had all the systemic signs of hypothyroidism, but then also noticed she had this puffy eye swelling in the mornings and suddenly her eyes were looking more prominent. She came after having gone to an endocrinologist, already diagnosed, and was on treatment. So since she really didn't have any functional deficit and her activity was really less in terms of only just soft tissue swelling in the morning, we just put her on supportive treatment in the form of maybe raising your head when you're sleeping, giving to your lubricants, giving some to your living gel in the night, and she was happy with that, and we really didn't do anything more, just observed her for any worsening. Coming to the second case, this lady came, again, she was diagnosed, but she came with a little bit of restriction, proptosis, upper lid retraction, but more unilaterally. And in her case, I did later do a CT scan because after about a 3-month visit, I felt she had worsened actually. And in that, her clinical activity score was about 3 to 4. But what we did is, we decided since she was worsening in terms of her lid retraction, subtlety and the fullness, we decided to with the supportive measure to go to the next level, which is to take in the form of steroids, which we gave her oral steroids. And currently she was on a medical management for hypothyroidism, but she was not responding in terms of the thyroid ophthalmopathy or the thyroid eye disease. And just, of course, over 6 to 8 weeks is what I start. And as Dr. Ganadhar said, even about the other things in specific condition, I am aggressive about steroids. I don't like to undertreat when the patient is 50 kilos and 30 milligrams, you give 50 milligrams, you give it as per the body weight, give the supplementary calcium and explain to the patient that there is going to be a Cushing syndrome, but it will get reversed. And And just with the treatment of oral steroids, the lid retraction went, her upper lid swelling reduced, and she was doing much better. Then this is a lady who was actually almost towards the end of her active phase and had eyelid retraction, little bit of lag of thalmos. She didn't really mind. But then as over the year and a half that we followed her, and she didn't have to, she had a moderate eye disease, she started feeling discomfort about the eyelid retraction. So we decided, along with the supportive measure that we were giving her, to do a botulinum toxin injection for the lid retraction. I usually give about 2 to 2.5 units transconjunctively, either in the paracentral mid area or laterally. In this case, we re-repeated, and I don't have photographs for that. But the first injection took care of a central lid retraction, but I've repeated about 2 units laterally to bring down the lateral flare, because she now is feeling much more comfortable with the lid retraction having come down. This is a lady who came, 50-year-old lady who came with a mild active disease. She did have a little bit of restriction, no diplopia, little bit of upper lid fullness, lid retraction, but she was fine with supportive therapy. Then 6 months later on a follow-up, she suddenly started worsening. Increased upper lid fullness, soft tissue sign increased, congestion, restriction, lag of thalmos. So we decided to try the first line of treatment as oral steroids. In her case, I did do a CT scan, but there was really not much on the CT scan except an increase in the orbital fat. So just with an oral steroid and supportive therapy, she responded very well, and 6 months post, her active disease has been suppressed and she is maintaining well. So this is a 24-year-old male came with active disease, which was actually, didn't look to me as have a high clinical activity score, but when I started examining him, he was giving a little bit of restriction, and complaining of grittiness. But then we did the CT scan because of his proptosis and his restriction and lid lag. And the CT scan was much worse. The CT scan had all muscles bilaterally enlarged. There was a little lacrimal gland fullness. So in this case, instead of giving it a trial of oral steroids, because he had soft tissue signs, he had lacrimal gland, he had extraocular muscles, pathos, we decided to take it to the intravenous methylprednisolone pulse therapy, which is in the form of 500 to 1 milligram, which I do as a loading dose over 3 days, and followed by either a bi-weekly or every 3 weeks pulse for 6 cycles. I don't usually do it every week. I keep it for every 2 weeks. So this is it after the first 3 days, the loading dose. And this is it now, about 9 months later, and he's sustained well. This is a lady who came with an acute thyroid ophthalmopathy, like we say. We gave her pulse intravenous therapy. She responded. After about 6 weeks, she again got acute thyroid eye disease. And we didn't know why she was not responding. She was non-diabetic. But because of the pulse therapy, she got diabetes, she got a host of other things such as pneumonia. So finally we had to admit her, because then her vision just suddenly started dropping and she would not respond to steroids. So we admitted her under low intravenous steroids. So when I initially given her, we were aggressive in 500 milligrams QID for 3 days. She responded. After 6 weeks when she came back, we discussed with the pulmonologist, the endocrinologist and the immunologist, because everybody got involved, and we decided to hold off her steroids and just go in for orbital decompression and do an endonasal medial wall decompression. And following that, we had to put her on a mild dose of steroids of just 5 milligrams to start the decompression, and she has sustained well. The only thing she's developed is a cataract in the left eye, because that has helped us, because otherwise she can have severe diplopia. Coming to the end stage disease. So often you see patients with all the lid retraction, the lateral flare, finally want where you intervene with surgical management. So this lady was keen on getting a better cosmetic appearance. And she went and underwent a bilateral decompression. In one eye, I had to do a 3-wall with fat, and the other eye I did a 2-wall, and with the upper lid and the lower lid recession surgery. And in some cases, you have patients who come, at least I see in our country, who come like this, who do not want anything. They're just happy with this. They have the squint, they have the severe upper lid retraction, and they just say, we're happy to be left alone, and I do just that. I just leave them alone if they're not bothered functionally and they don't have any cosmetic complaints. So to just speak about a few facts when we are managing this, is that not necessarily while an endocrinologist is managing the thyroid hormones, your thyroid eye disease is going to get get obliterated, but you do need to tell them, and the best analogy I give them is that when you take you may be in fourth gear of a car, but you're not going to stop the process. The car is still running, and that's what you need to treat and come back if you feel that there's any worsening. Smoking, I don't have any targets for the patients, but I do encourage them very aggressively to get off the smoking because it worsens the disease. And older individuals, as we know, have severe disease and the associations associated. Thank you so much.